Hello, everyone, and welcome to today's AFA Care Connection webinar. My name is Susan Shipman, and I'm a social worker here at the Alzheimer's Foundation of America. The topic for today is mild cognitive impairment, often referred to as MCI. What is it, and how does it relate to Alzheimer's disease? We are very glad today to be able to welcome as our guest speaker, Dr. Nathaniel Chin. Dr. Chin will explain what mild cognitive impairment is and how it differs from normal aging, dementia, and Alzheimer's disease. But first, a few housekeeping issues. All the lines are muted, but we encourage questions, so please feel free to use the question box on your screen to type in any questions you might have. We will have a brief Q&A at the end if we have time. Any questions you might have for AFA, please feel free to call our helpline, which I'll include in the wrap-up email along with your certificate of attendance. Additionally, Dr. Chin has graciously offered to provide a copy of his presentation, and I'll include that and the website and several other informative handouts so that you can stay connected to Dr. Chin's group and his podcast. He also has a book being published soon, and I'll make sure to update you all on that. All of that said, let's get started. Dr. Nathaniel Chin is an associate professor in the Department of Medicine and Division of Geriatrics and Gerontology at the University of Wisconsin. Dr. Chin evaluates and cares for patients at the University of Wisconsin Health Memory Clinic, where he also serves as the Associate Program Director. His clinical focus is on the early identification of cognitive impairment, appropriate inclusion of novel biomarkers in the diagnostic process, and the development of holistic approach to care post-diagnosis. He is the medical director of the Wisconsin Alzheimer's Disease Research Study, the Wisconsin Registry for Alzheimer's Prevention Study, and the Alzheimer's Disease Research Center Consortium for Clarity in Alzheimer's Disease and Related Dementias, Research through Imaging. His research focuses on understanding the perceptions and implications of biomarker disclosure, as well as the impact of addressing modifiable risk factors. He has created over 200 podcasts on Alzheimer's disease research and caregiving topics under his podcast called Dementia Matters. He is also an esteemed member of the Medical, Scientific, and Memory Screening Advisory Board of the Alzheimer's Foundation of America. And now I'll turn the talk over to Dr. Nathaniel Chin. Welcome, Dr. Chin.
Thank you, Susan, and I'm honored to be here, excited to be here with all of you. I appreciate you giving time to hear this presentation and really learn as much as you can about a very important condition of mild cognitive impairment. This is something that's very near and dear to me, and I look forward to your questions at the end. I do want to start by just giving you a little bit of context of who exactly I am beyond what the things that Susan said. And the reason I'm here is because of my father, and you can see a picture of he and I there in the left. And this is when my father had mild stage dementia, and he had Alzheimer's disease as well as Lewy body disease, which we didn't know about until after he passed away. But I'm here because of him, and I speak really because of that experience. And so, yes, I speak as a professional, but really it's also as the son of someone who is deeply affected by this disease. And then I also have a picture of UW, and I do that as a caveat because some of the things I say about evaluation or care when it comes to someone with cognitive change is really influenced by the fact that I do work at an academic center where we have a lot of resources, we have a lot of staff and a great team, and that's not always the case for everyone. So I want to be aware and recognize that the care across the country is going to be different. It's going to vary based on where you are. And so I won't be able to speak to that each individual sort of experience, but at least sharing with you my experience working at an institution like the University of Wisconsin. I have a few learning objectives after talking with Susan that I wanted to share with you. And a lot of this is really about mild cognitive impairment. And so understanding the definition of it, but also how it's different from dementia and Alzheimer's disease. understanding what that process could look like for someone with cognitive symptoms, including where biomarkers might have a role, and then exploring those causes, the potential causes of mild cognitive impairment, and then the treatment options after a diagnosis. And so I like to start with this figure here of, well, what exactly is normal aging? And there is normal aging and normal age-related change. And so let me see, hopefully you can see my mouse here. And so on this horizontal line is age. So you're getting older as you go left to right. And on this vertical line is cognitive function or cognitive ability. And that's and I'll explain that in just a second, but you're losing that ability as you go top down. And so before I talk about normal aging here, I do want to explain cognitive function is a series of abilities or a grouping of abilities that we have that we sort of take for granted until they start changing. The one most people think of is our ability to learn and recall things and have a short-term memory. But even for this to work, we have to have attention. We have to be able to focus and process information. Language is very important part of our ability to engage with others. That's understanding words, naming objects, communicating. Executive function is probably a term that's new for many of you, and that's an incredibly important function at the front of the brain. It is where we multitask and plan and organize and process and reason through things. And then visual spatial is actually the back of the brain, and that's how we see spatial relationships, our depth, the orientation of things. And so all of these are important abilities that do work together. And this is what I mean when I say cognitive function. And so normal aging is actually not a straight line, as you can see. There's actually a bit of a decline over time. And so in your mid 20s, about 25 to 30, you reach your peak ability. So this line probably should be over here, but this is where you're at your best. And afterwards, after about 30 or so, we start having some changes, some declines. Now they're subtle, and you're not really going to notice those. But then at some point, usually in your mid 60s, there is this sort of inflection or tipping point where there are more symptoms, more changes that you might actually be attuned to. And it might feel like you've actually declined in an abnormal way, but you haven't. It's just an accumulation of thinking changes. And what I mean by that, thinking changes, the ones in particular that we see that are very common in normal age-related change. Episodic memory are the things that have just happened to you, the events, the conversations that have happened in the past day or so. It's harder for people to retain those. And that, of course, is very scary because that could be an early sign of a disease process too. But to some degree, this is considered normal. Our processing speed tends to slow down as we get older. We need more repetition if we're trying to learn something. We're more distracted, and so we need a quieter space in general. The one I think is really hard, or the two that are really hard for people, are these bottom two, free recall and word finding. This is sort of the tip of the tongue phenomenon. And so in the middle of a conversation, you're trying to think of a fact. This would be the free recall or a word, and it's just not coming. And usually for many people, after the conversation is over, 5, 10 minutes later, that word comes to them. And that's actually quite reassuring. There's just an issue with retrieval of that information from your brain. We tend to see this more in normal age-related change. Now, for those of you that prefer seeing it in written format, this is some of the same information that I just presented in a little bit more detail as far as difficulty with learning and recalling information. But ultimately, these changes are subtle. They're not interfering with your daily ability. They're not happening all of the time, not every day. Others tend to not notice these things. And that's usually how we think of normal age-related change. But again, if it isn't, that would be a reason why you would talk to someone about it, ideally see your primary care provider. Some things do get better over time, and that includes our vocabulary and wisdom and usually emotional resilience. But why does normal aging happen? It's because unfortunately we lose brain cells as we get older. So there's brain shrinkage or atrophy. And so in this picture, you can see a robust brain that is in its 20s and then a healthy brain that's in its 80s. And it's just smaller. And that's because of the brain cells and the connections among brain cells that just decrease in amount. And so that's here the loss of connections at synapses. And a part of that is related to blood vessel disease. As we get older, our blood vessels get narrower. And so we can go from having kind of wide open blood vessels in our 10s and 20s and 30s. And then we just start getting some of that cholesterol blockage that is still considered normal. It can become abnormal if it's too small, but we do see that happening. And when there's a decrease in blood, there's a decrease in nutrients and oxygen, and cells will just pass away. So if that's normal aging, then what do we consider abnormal aging? And that's where we use a term like cognitive impairment. And cognitive impairment to me is one of the safest, most general terms we can use. It is a umbrella term, so it's just a description. It's not really a diagnosis or a disease, but it occurs when someone has a memory or a thinking complaint. And it could be the person experiencing it, a family member or friend that knows them, or even their healthcare provider. But then they also have to do the next step. And this is a big barrier for many people, but they go through some form of thinking test. And that objective test shows a lower score than one would anticipate for their age. And we would use these two pieces of criteria as a diagnosis of at least cognitive impairment, a description of cognitive impairment. But then the real diagnoses happen beneath this. And so there are two that we think of. The first one being mild cognitive impairment, and the next one being dementia. In research, we have a different term called subjective cognitive decline, where a person has persistent symptoms, but they don't actually have impairments on testing. I do anticipate in the future this will become a clinical term, but as of now, we're just using this in research. So then what exactly is mild cognitive impairment? That's why you're here. Mild cognitive impairment is not normal aging. It's something has happened, but it's also not dementia. And I think that's worth repeating. Mild cognitive impairment is not dementia. It's distinct from that. We define it by someone having that thinking complaint, having that thinking complaint representing a decline from what their baseline ability has been. An impairment, just one is fine, an impairment on those thinking tests. But then doing their day-to-day activities is still very much intact. There's no functional impairment. Now, they might need help, or they might need some strategies or compensatory strategies and aids to do their activities, but they're not disabled in any way. And so we think of this as this umbrella term, but then what actually causes mild cognitive impairment? And that's where there's a lot of different conditions. And some of them are brain related, so Alzheimer's disease, vascular disease, Lewy body, Parkinson's, another one's called frontal temporal. But then it's a broad category. There's a lot of other things like medication side effects, mood disorders like depression, schizophrenia, bipolar, and then underlying medical conditions like sleep apnea, a vitamin deficiency, a thyroid abnormality. All of these can be causes of a person's diagnosis of MCI. So how common is MCI? And you'll see here in this figure, it becomes quite common as you get older. A great risk factor is aging. And so in your early 60s, about 6.7%. In your early 70s, it's about 10% of the population. In your early to mid 80s, it's about a quarter of people will have mild cognitive impairment. It's actually quite common. And so what we see here, though, is that when a person is going from what we would call an unimpaired state to a mild cognitive impaired state, it's about 5 to 6% of people in their 70s overall. Those with mild cognitive impairment are at a higher risk of progressing to dementia, and I'll define that in a second. But it happens about 15% over a 2-year period of those who are 65 and older. Many people will cite that about 10 to 15% each year will progress from mild cognitive impairment to dementia because of whatever that underlying disease is. So after 4 or 5 years, about 50% of people will progress, but 50% won't. And so it's not everyone, and at least not at the same time. And so when it's due to Alzheimer's disease, meaning you're having proteins in the brain of amyloid and tau, the percentage is higher. And we see that because we don't have a cure yet for Alzheimer's. Now, there is a percentage of people, though, who get better. And so the conversion from mild cognitive impairment to being unimpaired is between 15 and 38%. And so this is the really important fact here, because if your cause is reversible and treatable, it's essential that we identify it, diagnose it, and then treat it, because people can get better. For clinicians, MCI is a prognostic conundrum. It's really difficult for us to tell people what their future looks like. And so I use this example of imagine three boxes. There's unimpaired, there's MCI, and then there's dementia. And so let's say you're starting with MCI. Well, it's entirely possible that you will have MCI going forward. It doesn't get dramatically worse, and you will pass away with MCI. It's also possible that you will progress to dementia. We just saw some of those statistics, but it's also possible that you actually get better and you have a diagnosis of being cognitively healthy again. And so it's hard for us to know exactly the determining the underlying cause is going to be really critical to this. And unfortunately, even if you do get better, there's always possibility that later in life you develop a different disease and you progress there from to MCI and again to dementia. So this is just really difficult to know, but it also stresses the importance of routine follow-up regarding your cognition. I think one of the key things for us in this country is to talk openly about our memory and thinking ability so that we can identify the earliest change and have an intervention as soon as possible. This comes from my colleague, Dr. Tori Williams, who's a neuropsychologist I work with in the memory clinic. And she just has, so this is the prevalence that I've already talked about, but she also has a couple of other risk factors when we think about who could develop mild cognitive impairment. And when we look at the population, it tends to be more males. It tends to be people who have less education. This genetic risk, this ApoE, for many people who've heard of this, ApoE4 is a risk gene for developing Alzheimer's specifically, but having that gene increases risk for MCI. Vascular risk factors are a risk, so diabetes, high blood pressure, being overweight and obese, high cholesterol, and certainly smoking. Other conditions like heart disease, atrial fibrillation, heart failure, having had a stroke, even kidney disease are now considered risk factors. But then, of course, having mood conditions, particularly if they're untreated, are also risk factors. And these are all things that we can start working on and addressing. We just need to know to do that, which takes talking to your primary care provider. So dementia is also not a disease. It's considered a syndrome, meaning a collection of symptoms. It's not the same thing as MCI. And so we define dementia as someone who has symptoms, a thinking symptom. It is a decline from their baseline. They now have had thinking tests, and there's at least two areas of those thinking abilities that are considered impaired. But then here's a key one. There's an impairment in their day-to-day function. Even with assistive strategies and compensatory, like sticky notes, phone cues, they still can't do something that they used to be able to do. And so that's a key defining feature. We think of dementia as being chronic and persistent and usually caused by a brain disease or a brain injury. So in this category, we don't think of underlying medical problems and psychiatric illnesses as causes of dementia. Historically, dementia due to Alzheimer's disease was not something we could identify with 100% confidence. We usually said it was someone who had a primary complaint in memory, that we've ruled out strokes, potential Parkinson's disease, and that we feel like the course has been gradually progressive. This has improved because of the use of biomarkers. We now can identify those proteins. But prior to that, we were doing our best with our clinical judgment. So I said dementia is not normal aging. It's not a disease, it's the consequence of a disease. And there are those five main brain diseases that I've mentioned, and you can see sort of a figure of how common they are over here, Alzheimer's being the most common, and Alzheimer's disease being the buildup of two proteins. It starts with this one called amyloid. There are likely lots of reasons that amyloid could become abnormally elevated in the brain. We're still trying to understand that. And then years later, this tau protein forms inside of the brain cell. And it's actually the tau protein that ends up killing the brain cell. So that's the most common cause, but vascular disease is probably up there as far as blood vessels getting smaller or too small, or having strokes. Parkinson's and Lewy body disease are proteins also building up. They're just not the same proteins as Alzheimer's. So one's called alpha-synuclein, the other is called Lewy bodies, and they are building up in different parts of the brain, causing the symptoms of these conditions. And then frontal temporal disease is a different protein called TDP-43, and it's building up in the front and the side. So all of these brain diseases, which many people have just associated with dementia, are actually just a biological process that's happening. proteins that are building up. So when someone has a cognitive impairment, it's not a mental deficiency. They're not choosing to be this way, and it's certainly not something they've asked for. It's these proteins building up causing those symptoms and changes. So Alzheimer's disease specifically are amyloid and tau. It's the most common. We've learned through our research that there's a very long pre-symptomatic stage, meaning amyloid can be in the brain for 10 to 20 years before a person actually starts experiencing a thinking change. We now can identify this on PET scans and spinal fluid, and we just had our first FDA approval of a blood test to identify amyloid in the blood serum, so simple blood draw. But other diseases can look like Alzheimer's, particularly vascular disease, or they can just co-occur. And actually mixed dementia or mixed diseases is becoming more common than singular diseases, particularly as we get older. So this is what a brain might look like. You can see in this picture here, robust. There's a lot of density to it. This is the memory center, the hippocampus. This is where we learn and start storing our memories. And this is what a brain with Alzheimer's might look like. It's just smaller, it's shrunken. There's more spaces here. And so if we were to look at the tissue within that brain, we can see a healthy neuron on the normal side here, and then on the side with Alzheimer's, we see these amyloid plaques forming outside of the brain cell, disrupting communication. And then we start seeing the tau protein, these neurofibrillary tangles inside, eventually leading to brain cell death. And we can see this actually on MRI scans. So this is meant to be sort of a similar image. And this arrow is pointing to a very small hippocampus, which is not itself diagnostic, but suggestive of Alzheimer's disease. And you can compare the two. And there's more space, there's more atrophy, more fluid or open space there. And this is what we have historically used to be supportive evidence that Alzheimer's is present. But we do want to think of Alzheimer's as sort of the sequence of events that can cause mild cognitive impairment. And so it starts with this amyloid protein. This is a PET scan showing the bright red and orange indicating the presence of amyloid. Years later, anywhere from 5 to 10 years later, we can see tau tangles forming, and that's the orange and red here. And then atrophy, brain cell death, and I just showed you that picture. But I draw this green line here because all of these things actually can occur without you experiencing any symptoms. And this is all thanks to research participants coming in year after year for 30 years, letting us do scans and lumbar punctures. We've learned this, but this is an ideal time for intervention or prevention. And then even with mild cognitive impairment, this is an important time for intervention. And I've already defined mild cognitive impairment for you, but an impairment on testing is important. And someone with dementia, and this is a picture of my father, they're going to have those functional changes. So I want to put it all together for us. This is that same figure I showed you at the beginning of cognitive ability on this vertical line, age on this horizontal line. Here's your line of normal aging. But in this individual who ultimately we'll say has Alzheimer's disease, slowly over time, they're building these brain changes, this amyloid and this tau. And as that's building, there becomes this deviation from normal aging. That's this red line. And as you are starting to change over this red line, you have more symptoms. You have symptoms that are not just normal aging. It's that plus the symptoms that come from the proteins. And if you go in to be evaluated, you might get diagnosed with mild cognitive impairment. And it's possible, particularly if it's a disease like Alzheimer's or Parkinson's or frontotemporal, where the proteins continue to accumulate, well, then you're going to progress and have eventually a diagnosis of dementia. And so this is how I put it all together for my patients who are coming in. Now, the cognitive evaluation is incredibly important, but it doesn't just happen in one visit. It's a multiple step process. And it's really important for people to get in as early as possible, to bring in people who know them well when they trust them. And that's because some of the information they provide is really helpful. And what a clinician is going to look for is a lot of history. We want to understand, when did symptoms start? What kind of symptoms are you having? How is it impacting your day-to-day ability? They should be looking for reversible factors like the things I'll talk about in a minute, but sleep apnea and medication side effects. They need to know your medical history because they want to know what risk factors you have for potential vascular disease or Alzheimer's disease, or if those conditions alone could be causing your symptoms. And that includes medications too. Eventually, blood work will be ordered, and that's to look for those reversible factors. A physical exam can be done, and that's really to look for evidence of Parkinson's disease or Lewy body disease, including a heart exam. And then most of the time, some providers will do a cognitive screening test. And I think this is important to get a sense of how is the brain performing? What does it look like on these, what feel like very random abstract tests? Many of them are, you'll see some called a slums, a mini mental, or a MoCA, but there's many of these tests. And the AFA is really good about conducting these, and they do free memory screens. And I think that's a really important piece of it. And this can help either support some of the symptoms a person has or actually suggest that these symptoms are not due to a brain disease because they do so well on the test. These are not definitive, but they are certainly helpful. And then a lot of people will get brain imaging, and I do think that that's important, particularly if the cognitive screening is lower than we think. And this is really to look for brain changes as well as reversible factors too. So when it comes to that cognitive history, what we're really looking for is a lot of richness to your story. What are you experiencing? When did it happen? Have others noticed it? What has the course been like over time? Is it progressive? Is it stable? Does it fluctuate? We're going to want to know the context in which this happened. Did you fall and then you had these symptoms? Did you start a new medication and then have these symptoms? Did you have a stroke and then you started having these symptoms? These things are really helpful in figuring out what could be going on. We want to know about your mood. Is depression present? Is that gotten worse? Are you being treated for that? Are there personality changes, behavioral changes? And this is really helpful when a person has a family member or friend come in as well. We still look for these reversible factors of sleep, hearing, and vision. And as I mentioned, we're reviewing a lot of your background, including your substance history. Yes, tobacco increases risk of vascular disease and Alzheimer's disease, but also alcohol use. If a person's drinking more than they should, that can impact not only their thinking, but even their sleep, which then impacts their thinking. And so there are questions that I encourage people to think about. Do you feel like your memory is becoming worse? Do you think it is, are you having trouble remembering things, and try to rate that? But I think this is an important one compared to 5 years ago or 10 years ago. How do you feel like your memory compares? There's actually good evidence in research studies that these are really impactful questions to ask. And so I encourage people to think about this, but I also encourage clinicians to ask these questions. For people who are interested in filling out their own sort of questionnaire and bringing it either to their primary care provider or as a way of talking to their family about it, for free online, you can find other questionnaires just looking at describing the symptoms that you're having. One's called the IQ code and one's called the 88. When people ask me, well, what are the earliest symptoms? The earliest symptoms are not an inability to drive or manage your medications. The earliest symptoms are thinking changes. And so if you're experiencing a memory change, it's usually about forgetting events or conversations, repeating stories, misplacing items. If it happens to be language first, word finding, problems understanding words, problems reading or writing. Visual spatial changes can happen, particularly with Parkinson's disease and Lewy body disease. And that would be problems with getting lost or recognizing people. It's the visual part of it. Difficulty understanding spatial relationships. I want to be careful because getting lost could also be more of an attention memory piece too. This is a very complex thing to drive. And so I tend to steer people more towards the idea that it's hard to recognize people, hard to see things that are right in front of you. Executive function can become impacted first, particularly in vascular disease. And so there'll be problems with reasoning, organizing, multitasking. And then attention. Attention is so critical to so many of the things that we do. It's also very easily influenced by medications and alcohol and poor sleep. But that would be problems with focus and difficulty following a conversation or a TV plot line. But the earliest symptoms are thinking changes and not daily function. And of course, that's a key part of having MCI is that you are still functionally intact. So that functional history really is critical to this process, to this evaluation. And I encourage everyone who's worried about their memory or thinking to ask themselves, how is this impacting me day to day? Having a person who's observed you is helpful from a clinical standpoint, but you don't have to, especially if you're just thinking about your own self. But there are some questionnaires that people can fill out there that are available online. I tend to say Look at what the instrumental activities are, and I'll show you a slide of that in a second. And just ask yourself how you're doing in these abilities compared to your baseline, not compared to someone else's standard. But then thinking about, are there safety concerns, especially if you're a family member watching this? Are there things that you're worried about when you think about these day-to-day changes? So here's the one that I wanted to spend a couple of minutes on because I think this is so important. One, it's important to understand what your thinking symptoms are, but then two, are you seeing changes related to those thinking symptoms? So is it harder for you to make and keep appointments, to manage your medications, to manage your finances? Yes, driving is included here, but meal preparation and cooking, doing your chores, using technology, using a smartphone or an iPad or a computer, and even to maintaining your hobbies. We consider these to be really complex activities and usually the first to change when someone is progressing from mild cognitive impairment to dementia. Now, basic activities of daily living include these, and this is really what it takes to get out of the house. You have to wake up, you have to transfer, walk, use the bathroom, bathe, dress, and eventually eat. When people start having impairments in all of the instrumental activities and some of these basic, that's when they've reached the moderate stage or more advanced stages of dementia. So that functional impairment, it's really important for us to recognize our baseline because we should not, if we were never good at cooking, then that's our baseline. So don't think that a poor meal indicates a decline if that's always been the case for yourself. I do tend to ask people, think about the more complex activities you do and start there to see if there are really any changes. If you can and you feel comfortable, talk to someone who knows you well and ask them if they are noticing those changes. You might not be attuned to those. It is a good thing to have compensatory strategies, using sticky notes, using a calendar, a whiteboard. I put my keys in my wallet in the same place right when I walk into the house so that I don't ever misplace them. They're always in the same spot. Those strategies are good for people. It reduces the burden that we put on our brains. And it's okay to make mistakes. That's the other thing is, especially for people living with mild cognitive impairment, they know how important their function is. And so when they make a mistake, they assume the worst and they think that this is it, that I've progressed to dementia. But people make mistakes. People get scammed. There are incredible scam artists out there and all of these automated services. It happens. And a person shouldn't just use one mental lapse as the reason they have progressed. And so it's important to look at the longitudinal history. How have things been over months and years? And then it is important to recognize that we can have functional impairments due to other things. If it's our mood, our lack of motivation, a physical limitation, that's different. And that's not considered to be a part of the impairment that would define dementia. This is really important. We need to always be looking for reversible causes. Even if we already have mild cognitive impairment and we know it's due to something else, these things can worsen those symptoms and make a person feel like they're declining when in truth we could treat these and have them feel better. And so medication side effects or interactions, always be checking, am I taking what I need to? Am I taking too high of a dose? Do I really need to be on this? Mood changes are incredibly powerful, especially depression and anxiety. Alcohol, I don't recommend anyone with mild cognitive impairment drink. Alcohol is a depressant. It suppresses the brain activity, it suppresses mood, and impacts our sleep. All of these things can inherently worsen our thinking ability. Sleep, I just mentioned, but even sleep apnea. Many people get evaluated for this if they snore and they feel fatigued during the day. Any sort of issues with our kidneys or liver, especially our thyroid, can be factors. Hearing and vision are factors. And then these are much less common, but people can have chronic infections that lead to thinking change. Where I'm from in Wisconsin, Lyme disease is more common. Syphilis, especially what we call tertiary syphilis, can affect the brain. HIV, back when it was progressing more to AIDS, can affect the brain. But even now, we're starting to see more of an impact of COVID-19 and its effects on the brain. Now, acute infections aren't causes of mild cognitive impairment, but they can mimic mild cognitive impairment. A UTI, a pneumonia can cause a person to feel confused and less sharp. And then the reason we get brain imaging is because some people can have a subdural hematoma. This is what happens after you fall and hurt yourself. It's sort of a blood blister inside of the brain. And these things are treatable and reversible and not something that would be permanent. another condition called normal pressure hydrocephalus. This is one that would be seen on a brain scan, and you would usually see a neurologist or a neurosurgeon actually to talk about this. Some people will have a shunt put in, and then their symptoms actually improve. So this is what it means to have a workup for those of you who are wondering, well, what is the next step if I am worried about having cognitive impairment, mild cognitive impairment, or I'm worried that I'm progressing within this condition. And so there's a lot of blood work that can happen, not maybe all at once, but gradually. We want to know about your kidney function. Kidney disease is not only a risk factor, but people can have symptoms from worsening kidney function. We're wanting to look at sodium levels and calcium levels, liver function. Thyroid is really critical. Having a high thyroid or a low thyroid can actually cause symptoms. I just mentioned this idea of infections, but even anemia when you feel very fatigued because your blood count is really low. Vitamin deficiencies, so B12, B1, B6, and D are checked in my clinic. These are related to the brain and the nerves, as well as vitamin D when it's really deficient can be a factor. And then, of course, your clinician ideally would be looking for things like a urinary tract infection, just if the history is consistent. I would recommend a brain image if you have persistent symptoms, you've had cognitive testing, and you have a lower score. It is important to look at the structure of the brain. Is the memory center smaller? Do you have blood vessels that are too narrow? Have you had a stroke that they identify that could be the cause? And then there's also those potential reversible factors like a hematoma or normal pressure hydrocephalus. When it comes to cognitive screening, it's not the same thing as full testing, but it can have a lot of value in determining next steps and how urgent is an evaluation. If a person has functional changes and it's due to their thinking ability, well, then that cognitive test can be really helpful in confirming that there is something going on, it has progressed, and there's more of a sense of urgency for an evaluation. But I do think it's important for you, if you're the person being evaluated, to ask, what is the name of this test and what are you using it for? Is this just to screen like we do with the AFA, or are you doing this to diagnose me? In which case, I might want to not take it immediately and because I slept poorly or I don't have my medications and I'd rather be in my best shape for the test. And so it's okay to not rush into this, but it is a valuable part of an evaluation. And when it is done, it is important that it's being done by a well-trained person. You want someone who knows what they're doing, that's following the rules, which is why it's so valuable having a service like the AFA where they're doing this regularly. You don't want me to do your memory screening test. I don't do it often enough to be really good at it. And so it's a technical skill. It's important to stick to the guidelines. It's important to understand what the results mean. And I tend not to use the cutoffs that are recommended because it's a full evaluation, as you saw on that other slide. It takes multiple pieces of information to come to a conclusion. And so people, especially if you're worried about the test, it should not be an all or nothing process. It's really just a piece of data. And I think people put too much weight into it, and that's too nerve-wracking for people. And so I think it's really good for clinicians to talk to patients about the value of it and also just the reasons they're doing it. Here are just a series of different screening tools. I just wanted to show you the list so that you know many exist. Um, some of them are briefer, so like the mini cog and some of these others are just a few questions, and some of them are more intense, and they can range anywhere from 5 minutes to 20 minutes. The more intense it is, the longer it is, it tends to be more helpful, particularly if you're very early in your thinking change. But ultimately, I think it's important that before a person jumps to the conclusion of Alzheimer's, we really figure out the syndrome, this idea of normal thinking change, mild cognitive impairment, or dementia, particularly because mild cognitive impairment has a lot of room for intervention and correction and improvement. And so it starts with, is there an impairment? Is this truly just a normal age-related change or something else? And we can get a lot of that through our history and talking about our day-to-day functioning. And if there is that functional impairment, it's really important to understand it. How serious is it? Is it related to thinking ability, or is there something else going on? Particularly personality. When people feel apathetic, they don't do the things they have historically done. And then this is why you want an evaluation, because you want to look for some of these other conditions full neuropsychological testing, which I understand takes a long time to get into, but that can be very helpful. Meeting with a clinician and having a physical exam, having a brain scan, these can help people determine, or at least they're clinically assessed for some of these underlying actual brain processes. When it comes to Alzheimer's, we now have the benefit of being able to look for the brain process, and that's through those biomarkers, the blood test, the lumbar puncture, and the PET scan. I certainly hope in the future we are able to do that with the other conditions like Lewy body disease, Parkinson's disease, and frontal temporal disease. We're not there yet, but the field is working on that. And so why is it that I even bring up these biomarkers? I just think they're really helpful once you know where you are as far as the syndrome of MCI to look for these things. These biomarkers are measures that are collected from your body, different sources. It could be blood or spinal fluid, and they're meant to reflect what's happening, what process is going on. And so we think of it as a diagnostic tech, maybe even a monitoring tool. In research, we're starting to look at it from a can it be helpful in predicting things or prognosing people? We've been doing this historically for a while with MRI scans where we show the hippocampus getting smaller over time, which you can see here. But the field is expanding in this way. They're looking at more ways of being able to tell people what's happening in the brain without actually getting into the brain. But even as exciting as these things are, it still doesn't replace talking to your family, your clinician, and understanding the symptoms themselves. But there's more to be done, and I just wanted to show you within the field of Alzheimer's alone, there's a lot of different things that we're looking at, not just amyloid plaques and tau tangles, but we're looking at inflammation. This is a huge part of the process in the brain. Are the levels of inflammation that are high enough that we can say that's a cause or that's a mechanism? We're looking at blood vessel function. We're looking at synapse dysfunction. That's the connection between brain cells. There's just lots of things that we can start studying in spinal fluid and blood. And then, of course, there's the imaging scans too. But the field is expanding so that we can provide more accurate information to people. But ultimately, when it comes to what can I do now, the management has to include brain health. This is something I know the AFA spends a lot of time on. And so this is a really important part of care. Brain health is really about optimizing your brain's ability wherever it is with whatever conditions it has. A part of that is addressing modifiable factors. What are the health conditions that could be causing this, the medications that could be causing this? And then what are the proactive steps we all can take to have a strong, resilient brain? And we think about a series of what we call pillars, brain health pillars, and sleep being one of them, getting enough sleep, physical exercise being a really powerful one, keeping your brain mentally active, avoiding the feeling of isolation and loneliness, feeling like you're socially engaged. Food choices is really important, so trying to have as healthy of a diet. And this diet is a hot topic issue, but really trying to avoid unhealthy foods, trying to eat more of the healthy foods, addressing your stress levels and your mood, and then certainly making sure your hearing, your teeth, your vision are being adequately treated if there are any sort of changes. I did mention that I would talk briefly about some symptomatic treatments or medication treatments. There's not that many, and the field has been slow in producing new medications. For the longest time, we have had what's called an acetylcholinesterase inhibitor, and I'll explain that in just a second. There are three of them, and you can see their generic name here, donepezil, rivastigmine, and galantamine. But look at this, they've been around since 1996. So these are relatively old drugs, but commonly used. And what they do is they allow your brain's ability to communicate to be at its potential best, meaning it does not create more signals, it does not stop disease progression, but it allows for communication to happen if it's going to happen. And so what I mean by that is these are two brain cells here. There's one brain cell that's going to give a signal, and there's another brain cell that's going to receive that signal. So if you've ever heard of the word dopamine, that's sort of a reward signal. Well, the memory signal is really carried out through what's called acetylcholine. So you have to pass that chemical from one brain cell to the next. And so you make this signal and you break it down naturally. And these drugs slow the natural breakdown of the signal so that healthy cells can have more opportunity to take it up. And that's how some people can report either feeling like their thinking is better or at least about the same over a period of time. And so that's how all of these drugs work. Another medication is called memantine, and it works on a different receptor in the brain cell, and it's meant to prevent the brain cells from being hyperexcited. This is not traditionally used in mild cognitive impairment. It's used more in the middle stages of dementia. Some people might be on it. There's not evidence for that, but that can be the case for some people. And then, of course, there are newer drugs if you have Alzheimer's disease specifically as the cause of your mild cognitive impairment or mild stage dementia. And I show this picture as a reminder that as of now, these are all through an IV. So I think of these drugs as like chemotherapy. You go to an infusion center, you're given this medication in your vein, and it goes into the brain and it breaks down the protein. So you can see here, we're forming amyloid plaques, and this is the amyloid plaque right here. This is the brain cell. And these drugs break this down and clear it from the brain. They aren't stopping the progression of Alzheimer's disease, but in the clinical trials, they did slow the progression of it. So someone with mild cognitive impairment is potentially eligible. There are reasons they might not be on it, but they are potentially eligible for these therapies. You have to know if it's Alzheimer's as the cause, though. Also, I think having the diagnosis can be powerful in getting to the right places, and that would include clinical trials. There's a lot of research programs across the country that are looking at mild cognitive impairment in particular. And it doesn't just have to be medication trials, it could be lifestyle trials. It could be things like we're doing in Wisconsin, looking at the biomarker part of it and trying to develop new tools. There's community organizations that can be really helpful, the Alzheimer's Foundation of America being one of them. The AARP has a bunch of scientists who form the Global Council on Brain Health, and that can be really helpful when it comes to brain activities. You can get a lot of that from the AFA, though. There are area agencies on aging, which are, county level support services. In Wisconsin, we have retired social workers and nurses who work in what's called dementia care specialists. And this is an amazing program. Not every state's going to have it, but states will have people who can help at least get you connected if you have mild cognitive impairment or mild stage dementia. So the benefits of an early diagnosis, it really provides information. It can help explain the symptoms that you're experiencing. It provides answers to people who are searching for the cause. It allows for earlier interventions, particularly access to support and services, including medications. And it can help a person really focus on what is my quality of life? What is it that I want to achieve? And how do I get there? It can help people, particularly patients, participate in their own care, discuss what matters to them, what are their care options. I encourage anyone, as a geriatrician, anyone who's over, well, not even over the age of 65, but anyone who's an adult to think about their healthcare power of attorney, their advanced directives, their financial, who's going to help them with financial decisions. And then ultimately helping people really focus on the changes they're experiencing, the functional changes, if any, safety changes, really getting your team together, and that includes your family and friends, so that you can become more educated about this whole process. And for those that are interested, Susan mentioned it, I have a podcast that does cover some of these in more detail. You'll have a flyer that I think is going to be sent to you, as well as this information. And I'm going to stop here so that I have about 10 minutes or so to answer any questions.
Thank you, Dr. Chin. We do have some questions, and just to reassure everyone again, you will receive a link to the recording from today, and you will receive a copy of the slides within the next 2 weeks. So just so we all just understand this, I know earlier in the presentation, you said what mild cognitive impairment is, and just to reiterate, it's not a form of dementia, but it is also not normal aging either. It's its own isolated diagnosis during that particular period of time. Do I have it?
That is very well said, Susan. That's absolutely right. It is not normal aging, but it's also not dementia. And it's a very important period of time because there's a lot of opportunity for interventions, for identifying reversible causes, and for maintaining and building that brain buffer to handle whatever's going on in your body and your brain.
Okay, now how important is it to schedule follow-up visits after a diagnosis of MCI? We have people calling our helpline who are noticing further behaviors in their family members, and we find out that they were diagnosed with MCI 2 to 3 to 4 years ago, but have not had a follow-up visit for their neuro visit.
I think like all serious chronic conditions, it requires routine follow-up care. I think it's really critical to not only get a diagnosis of mild cognitive impairment, but to also know what is causing it. And if the answer is we don't yet know it's something related to the brain, that's okay. But I also want to know that you've ruled out those things like sleep apnea and mood and medication side effects and thyroid. And there's a long list of things that we should look at. And so it takes multiple visits. So I would say, even if you get this diagnosis of mild cognitive impairment, you want to be seen every 6 to 12 months to make sure, well, where am I? Have we identified the cause? If not, have we ruled out and addressed these reversible factors? We tend to, in Wisconsin, repeat the thinking test every 1 to 2 years to see how a person is doing. Are they progressing? Are they getting better? Are they stable? And so it's not something where you just walk away and you're done. You've had this condition. It actually should prompt you to be aggressive about identifying the factors, keeping your heart disease, your other medical factors, conditions optimized, because you don't want those to be contributing to your thinking ability.
Okay, very, very good. And we've had a number of people write and ask how to reverse it, but I think you covered that in one of your slides. And again, everyone will receive the slide so they can address those issues with their medical providers. And I also want to ask you, because not all of us have a facility such as yours near us, how do you feel about telemedicine or telehealth? Many people in more rural areas don't have access to the kind of specialized knowledge and care that your facility would offer. Is it possible, first of all, to make an initial diagnosis and then follow-ups virtually? Or is it at least possible to make an initial diagnosis and then do follow-ups as telemedicine or telehealth?
It's a great question, and so first caveat, I am a big supporter of telemedicine and telecare. The difficulty when it comes to the initial diagnosis is that a part of this diagnosis, a part of the criteria to say someone has MCI, is you need that thinking test. You need to know that at a performance level, a person has lower scores. And that is harder to do virtually. It can be done. And so I do think the initial assessment can be done virtually. If you are doing more advanced thinking tests, like the types that we do in a clinic, it's really hard to do that virtually. And so I think there's some value in being able to go somewhere to have a thinking test done. But the information, the key information that we're looking for can all be done virtually. It's through a conversation that we acquire the history and the functional ability and the mood and the sleep activities, the hearing. So all of that could be done virtually. So much of it could be done remotely. Certainly after a diagnosis, for me, most of my care for those with MCI and dementia is done virtually for ease. And so that's because I don't need to physically examine you every time. And so I think if your resources or your situation require that I cannot come in person, I wouldn't let that stop you from getting as much of an evaluation and care as possible, because there are creative ways of doing testing remotely. And certainly the information you provide, which is the most important, can be done remotely.
Okay, wonderful. And we have an excellent question. Your chart went from your last entry was 80 to 84. We have someone asking, what is the MCI prevalence for those persons 90 plus years?
Well, that is a wonderful question and very astute observation. For the longest time, there wasn't as much research on 85 and older. And that actually has been addressed by the NIH. They came out and said, we need more studies specifically targeting an older population because people are living older. And so the figure I showed you came from a study that was, I don't know, 6, 7 years ago, and they just didn't have the data. And so the idea is these numbers are presumably increasing. And so we see 80 to 84, about a quarter of people. And the idea being, well, likely it's closer, it's higher than that. And that's really the safest thing I can say to you is it's higher in the 90s. Perhaps it's in its 30th percentile or more. We just don't know because we haven't been studying it to the same level as we've been studying 60 and 70 years old.
Okay, okay. So it needs to be included. And can you explain why males are more at risk for MCI, but females historically have been more at risk for Alzheimer's disease and related dementias?
Yeah, that is a great question, and I don't have a solid answer for you. We know that females are, in fact, 2 times greater risk of developing Alzheimer's disease specifically, and there's a lot of great research looking into that. Certainly, hormones are going to be a piece of that. There used to be this idea of, well, women live longer, therefore they're more likely to get it, and that's really been minimized now because we know there's more biologically to it than that. Now, historically, men have had, quote, less healthy lifestyles. And so there was the thought that perhaps that was the reason. I don't know if that's really the case anymore. And so they are now, research now is really making sure that we are including equal amounts of genders. And there are specific researchers looking at the gender differences. So ultimately, I can't tell you why that is the case. Um, Men tend to have more risk factors when it comes to cardiovascular risk factors, or at least diagnoses. And I don't know if that alone would be enough, but I can tell you it's being looked at within the field.
Okay. And can you advise people, and we have several questions on this, on general anesthesia in later years? One person reports that their family person is not the same person since a surgery after being under general anesthesia for several hours, and other persons are asking, what about general anesthesia for them?
Yeah. We actually have a researcher, Dr. Kurt Hogan at Wisconsin, who's an anesthesiologist that looks at this question. And what he has told me is to date, there isn't strong evidence that these newer anesthetics, these newer general anesthetics, are causes of a person having cognitive impairment. Now, these are the newer ones. These are not the inhaled ones. These are ones usually given through the IV. But what we do see is the surgery itself is a risk factor for having cognitive change afterwards, because we do see that people who are having cardiovascular surgery, heart surgeries in particular, we see there's this increased risk after having that surgery with cognitive change. I don't know if that's necessarily permanent, but they do see that. And so there's this idea that blood pressure can fluctuate so greatly during major surgery that the blood pressure variation could be a factor as far as those thinking changes. Now, that being said, I still tell all of my patients, particularly those with MCI, your brain is just more vulnerable, whether it's a fluctuation in blood pressure, whether it is an anesthetic, though that has, at least in our institution, doesn't feel like the case. You are more vulnerable to those changes, and it's unclear to me that you'll return to your baseline. We certainly see plenty of cases where people do, but we really have to ask the question, is this surgery elective? Is this truly needed? What is the risk benefit of this? Are you going to have a better quality of life if you have this done? Or is this just something that, you don't necessarily need? You can live where you currently are because you feel like the risk is greater than the idea of losing more of your cognitive ability. So these are really important questions that should be discussed with your surgeon too, and that many surgeons are open to these conversations. If it's an urgent and it needs to happen, well, then it needs to happen. If this is a life or death, or this is really critical surgery, then you do your best care after the surgery to make sure you keep your brain as active and healthy as possible. But if it's needed, it's needed in that regard.
Okay. And would you advocate for screenings for cognitive ability to begin earlier in life with primary care physicians? Many of our callers are furious because they're now at a later age being asked to prove that they're well oriented to environment and time. And if it was introduced as a normal part of a yearly physical, say, I think it would become part of the norm, and more of the incremental changes would be noticed earlier.
Yeah, and this is a debate within the field. And I am a believer that we need to normalize and destigmatize talking about cognition, arguably potentially doing cognitive testing. I think the question about cognitive testing is a little bit trickier because we don't yet know if a particular bad score in your 50s really reflects something is there or could just be a bad day. But I do think we have to be talking about our thinking ability as early as our 40s. Even if it's a brief one or two questions, you guys saw the ones I listed on my slide. I do think that needs to be a part of the standard medical evaluation. And I know it's included in the annual wellness visit, but I think it needs to be discussed more than that and in more detail when relevant. But I agree with everyone who complained that why is this only asked of older people? It feels a bit ageist. Granted, older people are at higher risk, but I do think when we as a culture, as a society, start openly talking about this, then it becomes normal. Then it becomes an active conversation, proactive involvement, and then testing when we're starting to feel like something could be different, even if we're just unsure, but it could be different. Then it's certainly reasonable to be doing more thinking tests in those situations. The
Yes.
idea of just testing everyone, I'm not so sure about. But I do know that we do that in research, and certainly it could be done.
Yeah, but at least some screening questions that start at an earlier time, so it's not doesn't feel like such a confrontation.
Absolutely.
Now we have several questions. How do I get my family person to visit the doctor once the family notices behavioral changes? This is one of the most difficult calls we get on the helpline. People are reluctant. They refuse to go to even see their primary care physician when their families suggest it.
Yeah, this is a really important and difficult question. Actually, this is chapter 2 of my book that will hopefully be coming out in the spring of next year. It takes family meetings, so it takes families being prepared, families, friends to be prepared to have a conversation. It takes a meeting with the person you care about, and then it takes a lot of thoughtful preparation in having that meeting. And the quick answer is I really think I statements are important. I'm worried about what I'm seeing. I'm worried about this. I'm concerned it could be something like this. I think it's valuable to look for sleep apnea, to look for depression, to look for vitamin deficiencies. Will you do this with me? And making it a we process of going in. Many people, in my experience, have been willing, even if they don't think there's anything wrong, have been willing for their loving family member who expresses this concern, willing to maybe humor them or maybe because they're concerned, willing to go in because of that angle. And then an evaluation can happen. And really the evaluation shouldn't be about, well, let's look for Alzheimer's. It should be about, well, what could be going on that's causing these thinking changes very broadly? And I think approaching it that way is less threatening and more normalizing and certainly more supportive.
So keep it about a wellness visit.
And this is why brain health can be so powerful. Reversible factors in brain health, and I would use those as ways of really just getting the context of what's actually happening.
Okay, wonderful. We have sadly come to the end of our webinar today. I want to thank you very much, Dr. Chin, for your time and the contribution of this tremendously informative and very detailed presentation. And thank you to everyone who attended today and for your thoughtful questions. Again, I will be sending an email in a few days following this webinar with a lot of information. Before we end, I want to encourage you to sign up for our next Care Connection webinar on Thursday, August 14th at 1 p.m. Eastern Time. Our guest speaker will be Dr. Charles Bernick, Senior Director of the Cognitive Disorders Section with the Cleveland Clinic Lou Ruvo Center for Brain Health. Dr. Bernick will speak about traumatic brain injury and dementia. Are they related? I hope you'll be able to join us. Take care, everyone, till the next time, and thank you again, Dr. Chin.